Good evening, everyone. Many thanks for coming for our webinar series of educating healthcare practitioners during COVID. This is our seventh webinar on ECMO. Our first speaker is Dr. Tim Hayes. He is a consultant anaesthetist and ECMO specialist at Wythenshawe Hospital. Tim, over to you, please.
Okay, thank you very much, Bhuvaneswari. You can see my slides. So delighted to spend my Saturday evening talking about respiratory ECMO. So I'm just going to basically give an overview of the UK, the respiratory ECMO service, how it works, what is the referral pathway, how do you get onto ECMO? Very, very briefly, because there's going to be quite a bit of overlap between some of the talks here. Talk about cannulation, mobile ECMO, which is probably more than 95% of our ECMOs, and just one slide on COVID, which I think there's another talk later on this evening about. So in terms of the background respiratory ECMO in the UK, it was really the pandemic H1N1, 2009, 2010. Prior to all this was just one adult ECMO service at Leicester. All the referrals went by them. And then obviously with the pandemic, there was a need for more ECMO centres. Centres were asked to put in bids for ECMO centres. These are commissioned by the NHS England. And Wythenshawe became an ECMO centre where I work in December 2011. That's when the bidding process. In terms of the backgrounds, just probably important where we work, we're one of the 5 UK transplant centres. We also look after heart failure, and we're a large cardiothoracic unit. And over the last 9 years, we've done over 500 ECMO runs, which includes both respiratory and VA ECMO. So in terms of the UK, or certainly England, there are 5 respiratory ECMO centres, which is governed by NHS England. You can see the Manchester, Wythenshawe, we cover this area here, Leicester, Papworth, and then there's 2 centres in London. So the country is divided up into 5 areas. So in terms of Manchester, we have different networks which can refer patients to us. So 38 intensive care units, which would, if they have a patient with severe respiratory failure, they would refer to us in Manchester. Similarly, in London, they will have so many hospitals which refer to the London centres. So who gets ECMO, or who should be referred for ECMO? So essentially adult-sized patients. So and where I work, we are adults. In terms of paediatrics, there are different centres which do paediatric ECMO. So essentially severe, acute, but reversible, considered reversible respiratory failure. Murray score more than 3, and we'll talk about the Murray score in the slides in a moment. Or uncompensated hypercapnia with pH below 7.2. And it should be very much a failure of conventional support of ventilation, including proning, prior to receiving ECMO. So it's a bridge to recovery of the presenting condition, and the reversibility is based upon experts' clinical opinion. And it can be difficult. In terms of, we're also a lung transplant centre, and lung transplants, if they need respiratory ECMO, they come under a different remit. So that's under our transplant service. So there is a new system. If patients are already under the radar, they can have ECMO prior to a lung transplant, or some occasionally, maybe one patient a year might require respiratory ECMO post lung transplantation. So inclusion criteria for respiratory failure, for respiratory ECMO. So it has to be severe respiratory failure for non-cardiogenic cause. Having said that, we've picked up quite a few patients over the years which actually turn out to be cardiogenic cause, but are still managed by respiratory ECMO prior to their cardiac surgery. Murray lung injury score, which we'll talk about in a few slides, more than 3 or more than 2.5 deteriorating. We've talked about the CO2, high CO2, which isn't controlled. And there's a few patients which might have a tracheal injury or bronchopleural fistula where positive pressure may be harmful, and those patients might get onto respiratory ECMO who don't meet the other criteria. So the inclusion criteria for ECMO roughly follows the original randomized controlled trial, which is the CESAR trial. So essentially, the CESAR trial had some inclusion-exclusion criteria. So this looked at adult patients, 18 to 65, severe, potentially reversible respiratory failure, again, looking at the Murray score. In terms of exclusion criteria, so patients are excluded if they've been ventilated for a long time, typically more than 7 days. If there's intracranial bleeding or contraindications to limited heparinization. And then I think this is an important one at the bottom. Patients who are moribund and should be palliative care should not have ECMO. So the real world, what have we learned over the years? Well, certainly in our centre, we'll take age more than 16 and sometimes younger, depending upon the size or the degree of urgency. On occasions, we help out our paediatric centres. Reversibility is still the key. Even if you're very young, you still have to have reversible pathology in terms of requiring ECMO. So ECMO may be suitable despite a low Murray score, so over the years, tracheal injuries, or ECMO to facilitate surgery. PEEP is a fudge factor, which I'll talk a bit about that. Age is not absolute, so in terms we have done patients over 65, but I think what's very clear is worse outcomes as you get older. Heparin is not an absolute contraindication to ECMO, for example, patients with heparin-induced thrombocytopenia. And we've done many ECMO runs without anticoagulation. Recently, in the COVID era, we've had several ECMO runs with no heparin for more than 50 days, with no harmful effects in terms of issues with the circuits. Non-cardiac causes, well, we do see patients with septic cardiomyopathies, and they can be still, on occasions, be managed with respiratory ECMO. And we picked up a few patients over the years with mitral valve disease or endocarditis, which we've managed with respiratory ECMO prior to their surgery, and again, respiratory ECMO post cardiac surgery until the lungs have recovered. So the Murray score essentially looks at 4 parameters: the PF ratio, the chest X-ray, how many quadrats are infiltrated, PEEP, and the compliance, how stiff the lungs are. Typically during COVID, many of our patients and the referrals we were juggling all had PF ratios below 8, and typically there'll be 4 or 5 patients on the go with between 7 and 8. So it was very difficult to make the decisions on who would get ECMO and in which order, in the terms of stacking up the referral systems. So essentially, what do I look for as a consultant? I like to see the imaging, terrible imaging and progressive imaging. So these are the patients who you have serial X-rays, and the X-rays are getting worse, and the general trend is they're going to get worse. On lots of oxygen, so typically the patients we put on oxygen on ECMO will be on 90, 100% oxygen. They've been proned a couple of times, and the PO2s will be 7s or 8s. Stiff lungs are always very worrying, so high pressures to get the tidal volumes. PEEP is probably the least in terms of, this can be a fudge factor. We can put the PEEP up at whatever we want on the ventilator. That's probably the one in practice we pay the least amount of attention to. And it's trends. So if it's a deteriorating trends despite optimal treatment, certainly should include proning. If there's fluid issues, fluid balance, that should be dealt with first. But these are what we look for as a centre. So during the pandemic, the recent one, NHS England have put some revised criteria down. Most of these are very similar, but there's a couple of things which they've added into. So frailty scales, this is the first time these have appeared for us. So it's just a way of, getting a bit of extra history from the referrals. RESP scores have now come into it. This again is looking at age, patients who've been ventilated for a long time, those patients which have had a cardiac arrest prior to ECMO referral, and again there's some more exclusion criteria. So this is similar to what we've always done, but it's just added a few more criteria onto, in terms of how do we make decisions who gets ECMO or not. So respiratory ECMO over the years, these are the most common ones. They're clearly infection, viral and bacterial. Viral infections, H1N1 was very good in terms of ECMO, very good outcomes, whereas the recent pandemic, which we'll go on to show, maybe the outcomes have not been as well as other causes of viral pneumonias. Aspiration, trauma, asthmatics do very well. And we're a big burn centre, so over the years we've had quite a number of patients with severe burns, fluid overloaded, go on to ECMO, and again, generally the results are very good. So in terms of our patients and our referring hospitals, this is what patients will be referred. They will follow the basic intensive care guidelines of ARDS, which would include lung protective ventilation, prone positioning, neuromuscular blockers. And if those things haven't worked, then we would expect, patients to be referred to as the local ECMO centre. Recently, the ECMO across the UK in terms of respiratory is now all goes via a computerized system. So it's a very good system. So there's lots of details. We can see each other's referrals from other centres as well. So from audit purposes, very good from that. You've got lots of details which we ask our referring hospitals to fill in as well. So what happens when we get the referral forms? We also like to see some imaging. And then with that, we have to make a decision. Is this patient a candidate, yes or no? Do we have enough information? How are we going to get more information? The next question, have they failed conventional management? Is there anything else we should be doing to optimize them prior to ECMO? And then with that, we either accept the patients. Some of these patients we feel that we can manage in the referring hospitals, who might say some advice. That might be fluid balance, putting on the filter and taking fluid off, proning, trialing a proning, trying nitric oxide if that's available. So all our referrals, we have a weekly MDT at our end, and so all the referrals are discussed in the MDT. It's a way of learning. All our patients are followed up irrespective if they refused ECMO or the advice is given. They have a 7-day follow-up to see the outcomes. With this new system, all the responses, whether that's advice or even declining treatment, we have an email system back to the referring clinicians, so there's documented evidence of that, and everything goes into our database. So we're able to see our results, all our referrals as well, and from our own learning as well. So essentially, majority of patients are all transferred on ECMO, and that's one of the biggest advances probably over the last 7 or 8 years. Previously, looking at the Caesar trial, patients were transported by land ambulance and then put on ECMO once they got to Leicester, whereas generally the majority of our patients are all put on ECMO in the referring hospitals. In terms of who goes out, well, we're a large team, so there'll be an ECMO consultant. Sometimes there'll be more than one consultant, or some of the trainees will come for training purposes, the ECMO coordinator, perfusionist, and then because we're a teaching hospital, often several other people can come along as well if available, just to watch and be trained as well. So in terms of what we've learned over the years, simulation plays a large part, and Laura, who's speaking later on, she's been fantastic, one of our lead nurses for ECMO in terms of simulation and all learning before we go. We have a designated transfer trolley where everything is all ready to go. The ECMO consoles are all welded into the ECMO trolley, so in the back of the ambulance, when you're going at great speeds, you feel the patient is secure as well. So in terms of cannulation, this is very brief. I'm sure we'll cover this more. For respiratory ECMO, if you look at the majority of ours, there'll be femoral drainage through the pump, oxygenator, and return for the right internal jugular. And that will be either the left or the right side, depending often on whether there's any devices already in. The majority of times, if the groins are clean when we get there, most people put, for ease, a right femoral drainage in and a right return. We have availability of dual lumen cannulas, so it's just one pipe into the right internal jugular vein. I've got some pictures of that coming up. Or we also have femoral configuration, and we've just got some new cannulas which make that a bit easier in terms of recirculation as well. So this is a picture of the dual lumen cannula. So if we're going to place these in, the important thing is this has to be done in the cath lab. So we need imaging. It's very important that the guide wire goes through the heart down the IVC, because these are big dilators and big pipes. If it's curled up in the right ventricle, then we can cause a severe amount of trauma as well. So to do this, patients have to be well enough or stable enough to go to the cath lab. Otherwise, we can do the 2-stage cannulas at the bedside. So these are typically what we would use. We have a mixture of either short venous drainage or long venous drainage, where there's a series of drainage holes as well. And then we typically would use an arterial cannula for the neck. So these are shorter cannulas, and they come in a variety of sizes as well. So if we're doing this at the bedside, we will do under transesophageal echo. So we like to see the guide wires. So you'll see the guide wire in the IVC, just to make sure it's in the correct position before we dilate as well. So in terms of the pathway, so we've accepted them for ECMO, we go and retrieve them, and typically we'll put the patients on ECMO and then we'll transfer them back to Winshaw for our mobile. The average time on ECMO, non-COVID, is about 2 weeks, just over 2 weeks typically. And then post-ECMO, we generally, once we're happy the patients are stable, we repatriate them either to their base hospital where they've come from, or to our general intensive care in our hospital. All our patients are followed up, they're invited back, we keep diaries, and there's also a clinic with a whole battery of tests to see how well and functionally they're doing once they've recovered from ECMO. In terms of ECMO, this is very brief because this is, I could talk for 45 minutes in terms of what do we actually do to get patients better on ECMO. So essentially the principles, ECMO is a supportive treatment. The main thing is it's rest ventilation. So these typically are patients who've had very high peak pressures, very high PEEP. So the first thing which we do is when they come to us is actually rest the lungs. So that would be typically 20/10 of pressure control ventilation, a low respiratory rate. Some patients, if there's severe airway bleeding, may not be ventilated at all, and we've had ET tubes clamped off for some period of time. We optimize the fluid balance. Many of the patients, not COVID particularly, because COVID, one of the things is we found a lot of patients are euvolemic when coming to us, but many patients, particularly the burns patients, are very fluid overloaded, and some patients just need between 10 and 20 kilos of fluid taking off them before the lungs will get better. We do regular CT scans, so typically within the first 24 hours, the patients will have a CT head, chest, abdomen, pelvis, and then at 2 weekly intervals for disease progression. And it allows us to buy time on ECMO, so a battery of blood tests, microbiology, and on all the respiratory ECMO does is buys time for recovery. So I like to think of it as three phases really of ECMO when the patient's with us. There's this resuscitation phase. So this is when the patients are first put on ECMO, and they can be unstable. They can be very, very sick on lots of vasopressors. So there needs to be a process of resuscitation. And then there's this stabilization phase when the patients, the circuits are stable. It might be that we've now got the right diagnosis, the right antibiotics, and the patients are now well enough to enable us to take fluid off on the filter. And then we get to this recovery phase as well, where then is the time when the imaging is getting better, then we'll try them off the ECMO, and hopefully once off ECMO, then they'll go to our general intensive care unit. Post-respiratory ECMO, what happens? So our patients, if well enough, we'll aim to repatriate them back to the base hospital. If they're complicated patients or the imaging is still not as good as we would like it to be, then we may keep hold of them, and sometimes that can be a lot longer, 2-3 weeks on our intensive care, or they might be transferred down to our general intensive care unit. Certainly with the COVID, we've been using more steroids than what we've done before, and some of these patients will need careful management plans what to do with the steroids. Typically, our patients on respiratory ECMO will be on very high sedation requirements, and we need to have plans what to do with that sedation. We scan all our patients regularly with CT scans, but also post removal of the ECMO pipes. We scan all the groins and the necks looking for thrombus, and it's very common. It's very reported, at least 50% in the medical literature. If we see both occlusive and non-occlusive, then typically if there's no contraindications, all our patients will get anticoagulated for at least 3 months. And like any other sick intensive care patient, muscle weakness, respiratory weans, there's a process which needs to go through, and many of the patients will end up with tracheostomies. If the patients get better, then they'll be followed up in the clinic, and all our patients have a diary and opportunity to see psychologists if the need arises as well. So just a couple of slides in terms of outcome data. So this is looking at some data April 19 to March 20 and in comparison with the previous year. So in a typical year, we'll get 150 referrals, of which probably about a quarter will go onto ECMO, be accepted for ECMO. In terms of survival off ECMO, it's typically what we've seen over the years. 70 to 80% of patients will survive off ECMO. In terms of the last years, maybe not as good as the previous years. So just over half of our patients who are very, very sick, needing respiratory ECMO, will get home. Previous years, that's normally about 65 to 70%. And I think looking at the reviewing, we've just had a lot sicker patients in the last couple of years. Certainly a lot more multi-organ failure going into ECMO. In terms of the COVID ECMO data, so COVID is a very different disease. So just looking at March to July of this year, well, we had more referrals in 3 or 4 months than we did the previous year. And we've done 37 patients have had ECMO in our centre, and 1 have gone off to Leicester because of bed capacity. Just, I think there's a talk later on, but just one slide really about my own impressions with COVID and ECMO. Certainly what we've seen, longer ECMO runs, on average 1 week longer than what we typically see. It does behave as a very different pathology to the other pathology which we put on ECMO, or some of, certainly swine flu, very good results from ECMO, and the COVID, it behaves very differently. I think looking at our results at the end of this COVID ECMO, we probably will see between 35 and 40% of patients being discharged home. That's what we're looking at the moment. So not as good as normal. Thrombosis we know about, so very common to see thrombosis in our patients. That's well reported. But what we have seen is more bleeding on ECMO than what we've seen before. We've had thoracotomies on ECMO. We've seen a lot more intracerebral bleeds than what we would typically see. And this has been challenged in a small subset of patients. We've used more steroids than what we would do normally. And with that, although often single organ failures, we've certainly had a lot more infections and bacteremias. And this may be also because the ECMO pipes are certainly in for that much longer as well. We've seen a lot more barotrauma than what we've seen before. Pneumothorax is a lot more chest drains. And I've just put this in question marks, the recovery phase. You get the impression that a lot of the patients who come off ECMO normally are very confident when the ECMO pipes come out that the chest x-rays and the imaging is looking back to normal. But this is not the pattern which we're seeing, that a lot of patients are coming off ECMO, but the imaging certainly is either lagging behind or they're still very stiff lungs when they come off ECMO. So in summary, a very brief talk really, but I've given or tried to give an overview of the UK respiratory ECMO service, how patients get referred into ECMO and the criteria for that. Very, very briefly about cannulation and mobile ECMO, and then just a slide which there's more to be talked about COVID and ECMO later on. Thank you.
Thank you, Tim. Thank you so much. And I know that our ECMO team, including you as a specialist, done a great job. Any questions for Tim? Please type. If you don't want to ask question, you can type or unmute yourself to ask question, please.
Tim, thank you very much. It's a very excellent talk, actually. I think you put a lot of effort for the COVID ECMO, and it's a very, very good overview of UK ECMO service. Just one question, one or two things you pointed out is very important, which is the reversibility of the pathology, as well as the failing of the conventional treatment, which is the most important points, I think, to take it, actually. Just one simple question. Do you think that our COVID results are slightly better compared to pre-COVID era?
So pre-COVID era, if you looked at swine flu, these were young, fit patients who were getting, so the perfect ECMO patient, if you like, was swine flu. So these were young, fit patients who are normally fit and well, and they get really sick really quickly. And what we found with these subgroup, these viral pneumonias and the swine flu, you put them on ECMO, they were very, very sick when they went on ECMO, but after 2 or 3 weeks of ECMO, they came off ECMO, the x-rays got better, and they did very well. What we found, and it's the same with, the COVID picture mirrors the general intensive care. Looking at general intensive care data of COVID patients, we know that outcomes aren't as good as normal general intensive care. The lungs, certainly we're seeing more fibrosis, we've seen more pneumothoraxes, barotrauma. But again, these are very, very young patients, which were typically, I don't know what Laura might know, our average age of patients. It's probably been about 40, 42, hasn't it? 45, which we've been putting on ECMO. But I think we've just all found it's very hard work. It's been a lot longer in terms of the reversibility. But we've managed to nearly get probably 35 to 40% of patients home, and they're doing well back to their young families. So
that's very good, actually. Yeah, thanks. Yeah.
Tim, there are a couple of questions for you. In cases of heparin-induced thrombocytopenia, what alternatives uses in your center, or what experience you have using alternatives instead of heparin in ECMO?
Yeah, so that's quite easy, really. So the question is, so the first thing, the important thing is to diagnose it. So I think over the years, we've got a lot better at diagnosing it. If we see a falling platelet count and and we want the patients anticoagulated, i.e. they're not bleeding, then we just typically would switch to our Argatroban. So that's what we use because that's what we found very easy to monitor with MPTTs. We would then send the test off. If they're negative, and we truly believe they're negative, then we'd switch them back to heparin. Otherwise, we'll just run the circuit with our Argatroban, and we've run many patients with our Argatroban, and it's a very good anticoagulant. The other thing, while the question's on, not just respiratory ECMO, we have over the years a number of cardiac patients who may require transplantation who have HIT. So then over the years, we've realized that trying to manage bypass, which is obviously what you need for a transplant, is very difficult with our Argatroban or other alternatives to heparin. So in those patients, if you're concerned, we would typically plasma exchange. And we've also plasma exchange patients for HIT on respiratory ECMO before now, if they've had. So for example, if they've got thrombosis and we're struggling with our Argatroban in terms of they are still very clotty with low platelet count, then typically we get on and plasma exchange them. And these are often the very, very sick patients on an awful lot of noradrenaline. So sorry, a long-winded way of answering. We in our center would use our Argatroban. If we were concerned about bleeding, because occasionally, you know, they can be thrombosis and bleeders, then we would go for early plasma exchange in those patients.
Thank you, Tim. Another question is for you. Role of ECMO in elective thoracic surgery, specifically tracheal resection, and appropriate pathway for referral for such elective procedures, please. Any?
That's a good question. I think we are gathering experience as the years have gone by. I think what I would say is it should be done in centres who are used to running ECMO. So it's not the ECMO per se, but it's everyone who's used to doing it. So with that, it's the coordination. So your surgeons in your trust might not be used to using tracheal resections, so therefore they have to come over here. So there's lots of planning. You know, who's going to be doing the operating? You're going to have unfamiliar teams. It's the coordination of the perfusionist, the anaesthetist, the nursing staff. So it can be done, but what I would say is, like anything, for results to be good, and we've done quite a few and they've gone very well, it needs a lot of planning and should be done in centres which are used to using respiratory ECMO. And maybe that means the operative surgeon, who may be the tracheal expert, comes to your centre to do it. And that's what we've done a few of. And we'll probably, over the next number of years, we'll probably get more experience because we have done an awful lot. We've done some patients who have had injuries just from intubation, which we've also managed. And these are patients which may not have got onto ECMO because of other comorbidities, but they haven't had ARDS. So we've put them on ECMO to do the repair, and they've been a quick wean at the other end. So it's not always the criteria which we talked about earlier.
Just before you go, Tim, a couple of questions. Are they using hemoadaptation therapy, cytosorb, in your ECMO COVID cases? Or if it is, what have you been your experience?
So very good question. So we haven't. I know only 1 out of the 5 ECMO centres have been looking at this, and that's during for trials. I think the jury's out. We use cytosorb or equivalent for in theatre, but we haven't got much experience on our intensive care of using it. I think, you know, it certainly needs looking at in terms of research. I think for the COVID, there is research going on. And again, I know one of our centres was trying to organise, you know, looking at different arms, whether that be plasma exchange versus cytosorb versus conventional treatment. So there is some research in that. We haven't used it, certainly for COVID or on intensive care. We have, if on respiratory ECMO in multi-organ failure, very, very sick patients, we have used plasma exchange plenty of times. We've got a good experience with that, but not absorbs.
Okay, final question, please, Tim. Have you, MDT, found rehabilitation with the COVID ECMO cohort?
That's a very good question. So I think there will be an awful lot of rehab, and there's national guidelines looking at this as well, isn't it? And it's not just, it's looking at all systems, and not just, so from a physiotherapy point of view, from a psychology point of view. So what will happen when all our patients, they will come back, be fed back into a clinic, I think in terms of the trust, there will be trust, a lot more clinics involved. There's a lot more money in terms of nationally looking at these patients when they go home, because there's a recognition that there's going to be a lot more probably chronic. Some of these patients might have, worsening lung function compared to normal. There's a worry about fibrosis, isn't there, in some of these patients? So there's going to be an awful lot of work from the rehab. And I think we're only at the point of probably, the patients have been home long enough recovering to now then get fed back into the system for the rehab.
Thank you so much, Tim. Many thanks for coming. Please go and enjoy your pint. And we will start with our next speaker is Mr. Sendhil Balakumaran. He is our consultant locum cardiothoracic transplant surgeon and also retrieval surgeon. Sendhil, to you, Sendhil.
Thank you, Bhuvaneswari, for the inviting for this webinar and organizing everything. It's a fantastic piece of work. Veno-Arterial corporeal membrane oxygenation. We can talk a lot about it. I'll just give an overview and management of it. Next, please. VA ECMO is an extension of modified partial cardiopulmonary support, which is mainly used to support a potentially reversible cardiac, pulmonary, and cardiopulmonary failure. Mainly, the first successful VA ECMO was done by Beff et al. About 1970, and it has been progressively increasing. It's important to talk about COVID during this crippling pandemic. Basically, in a recent survey from the Euro also, it showed that in August, up to August 2020, is over nearly 1,400 ECMOs were performed and about survival rate of 55%. Mind that it's not all VA ECMO, but it's majority of them BV and small proportion is BA ECMO. Next, please. Looking at the design of the VA ECMO, it's very simple, where there is blood is drained from a vein, which is here is the diagram showing the central VA ECMO. Is blood drained from the right atrium, which is pumped by a centrifugal pump, which is afterload sensitive and preload dependent pump, which pumps through the oxygenator with the polypropylene oxygenator, and then it goes into the ascending aorta, the oxygenated blood. So it's a simple extension of the cardiopulmonary support and cardiopulmonary bypass, what we commonly use in a cardiac surgery. Next one, please. But there is important differences between the VA ECMO and the cardiopulmonary. Go back, please. One back, please. There's an important difference between VA ECMO and cardiopulmonary bypass. Cardiopulmonary bypass, where it is an open circuit, majority of the cardiac surgeons and cardiac anesthetists are familiar with that, include a large reservoir and cardiotomy sucker where blood is in contact with air and environment, which initiate the inflammatory reactions as well as potential thrombosis. And so that for that you need a infinite anticoagulation. You need to keep the ACT more than 400 majority of time, and hemodilution and hemolysis, anemia are more common. And because of the environment contact with the blood, hypothermia gradually sets in and difficult to control. Whereas ECMO is a closed circuit, there is no reservoir. You can manage the ECMO with minimal anticoagulation, almost 50% of anticoagulation what is required for cardiopulmonary bypass. So we run around 180 to 200 ACT, and especially if you use a heparin coated circuit, which Elena might be touching later, you can even run without anticoagulation as well. And then normothermia, since it is a closed circuit, normothermia can be easily maintained. Next, please. Indication for Veno-Arterial ECMO is cardiogenic shock and cardiorespiratory failure from various etiology, like cardiogenic shock from myocarditis, ventricular septal rupture, and massive pulmonary embolism. Post-cardiotomy, low cardiac output syndrome, and failure to vein bypass can be supported with ECMO, and ECPR, extracorporeal cardiopulmonary resuscitation for the witnessed cardiac arrest, can be used as advanced adjuncts to the further to the ALS and COLS treatment, and a bridge to LVAD and bridge to transplant. All indications should be either have a reversible pathology, and if they don't have a reversible pathology, they should have a definite treatment and exit strategy. Next, please. Contraindications for ECMO, VA ECMO is intracranial hemorrhage, and uncertain neurology, active bleeding, either GI or pulmonary hemorrhage. In fact, cases of aortic dissection and aortic regurgitation. And those who had unwitnessed cardiac arrest, you don't know what's their downtime. And those who don't have any irreversible cardiopulmonary pathology, it's absolute contraindication. Relative contraindication, those who had a recent CVA, especially if they have a intracranial hemorrhage rather than ischemic stroke, that's more important. And cardiac arrest more than 30 minutes is also a relative contraindication. Next, please. Cannulation. Cannulation is mainly two types. We call central VA and the peripheral VA. Central VA is mainly intrathoracic cannulation, which is basically arterial cannula is placed on ascending aorta and the venous cannula in the right atrium. And peripheral VA ECMO, any artery like femoral artery, which is commonly used, and axillary artery. And in pediatric settings, we used to use the carotid artery, and venous drainage for the peripheral ECMO, either femoral veins or right or left internal jugular can be used for a venous drainage. Next, please. This is a diagram showing that peripheral VA ECMO, where the blood is drained from the right femoral vein, which pump back through the left femoral artery. Peripheral VA ECMO is basically a relatively easy application, and is easier to use in emergency situations. The problem with that is it comes with the poor RV decompression. The drainage is mainly depend on the venous cannula, and advantage of that is peripheral ECMO comes with the less bleeding complications. And if they are using the femoral cannulation, isolated limb perfusion cannula is also needed. Central ECMO is intrathoracic cannulation, where you get a good drainage. You can use a bigger venous drainage pipe, good RV decompression, and especially you can easily easily establish the full support. That means you can go to flow up to 4.5 liters easily. And it comes with a price. There is a high incidence of bleeding, and if it stays longer, sometimes you have to leave the chest open, and infection and mediastinitis follows. Next, please. So I'll just, Laura is going to talk in detail about the VA ECMO management. I'll quickly touch on it. Important points, it should be performed, as Tim mentioned before, is a specialist critical care unit with a specialist team experienced in medical ECMO, experienced medical and nursing staffs. And VA ECMO is slightly more complex than VV ECMO because the VA ECMO circulation runs in parallel with the native heart. So the competition between these two circulation changes as the patient physiology changes. So one should have a good experience with that and able to identify the problems. And the key point in managing these, keeping adequate pulmonary flow to prevent any intrapulmonary thrombus, and most importantly, preventing LV distension while maintaining the optimal vital perfusion is absolutely essential for a patient survival of ECMO. So monitoring cardiac output in this situation cannot be much easier. Conventional Swan-Ganz catheter thermodilution techniques are not reliable, so we do more often TOE, and it needs more experience. Next one, please. As Tim mentioned, lung ventilation, normally continue on rest settings, low tidal volume strategy. And we rely more on the central venous saturation. We try to keep about 70 to 85%, which gives a good ratio of VO2 and DO2, rather than just if we measure the peripheral ABG, it only gives about DO2. Once VA ECMO established, we tend to aim for the negative balance. Most of these patients tend to be kind of fluid overloaded following their resuscitation, following their cardiac surgery and cardiogenic shock. So we tend to keep them negative to help the pulmonary edema as well as to prevent the other complications. And we also, early initiation of CVVH is recommended if there is impending renal failure. And in general principle, during the early period of the ECMO support, it's better to avoid invasive procedures like tracheostomy or intercostal drainage to avoid bleeding complications. Next one, please. I'll just briefly touch on the myocardial recovery. Myocardial recovery is mainly based on a myocardial reserve and a reversibility of the pathology. Repeated TOE monitoring is vital during the initial period of stabilization as well as during the weaning from VA ECMO. Prevention of LV distension and optimizing the coronary perfusion is the two key factors for myocardial recovery. I think we need to use, if we find LV distension, we need to use LV venting. If it is central ECMO, we can use a right superior pulmonary vent. And pediatric setting, atrial septostomies have been performed with good results. And the use of intra-aortic balloon pump is also helps to enhance the myocardial recovery, and it decreases the afterload and prevent the LV distension, as well as it produces some pulsatility, which helps the physiology. It mimics like a natural physiological blood flow. And there are some recent evidences showing that it is improving the cerebral perfusion as well. So we continued some minimal inotropic support because it helps to enhance, it helps to pump the heart and maintain the pulsatility and prevent the LV distension. Next one, please. Weaning from ECMO myocardial recovery should be fully assessed before weaning from the VA ECMO. And it's absolutely essential full anticoagulation during the time of weaning, because as I mentioned, the two parallel circulations and the competition, the flow turbulence can causes thrombogenicity, and it is a complex exercise. It should be done gradually over 12 to 24 hours period, and TOE guidance is absolutely vital. And when we are weaning ECMO, it's always better to have appropriate adjuncts like nitric oxide, inotropes, and intra-aortic balloon pump. And if somebody needed significant inotropic support, there's no point. Clearly, their myocardium is not recovered. They're not at the point pushing them from the ECMO. And when we wean from ECMO, there should be a clear exit strategy, and it should be discussed with a multidisciplinary team, ECMO team, and plan should be discussed with the family as well, because as you can see, also registry and all registries, our experience as well, about 10 to 15% of patients, those who even come out of ECMO, still could die in the hospital before hospital discharge. So it is very important. And even after weaning ECMO, I think monitoring and supporting them appropriately in the critical care is very important. Next one, please. Let's quickly look at the overall outcomes. It's just from the ELSO registry, you can see about 27,000 adult VA cardiac ECMOs were performed. There's wean from ECMO is about 59%, and the survival for discharge. There's about 15% attrition in the hospital, 44% survival to discharge. And the outcome is also variable, depends on the etiology. Next one, please. So if I dissect the data into further, you can see the post-cardiac arrest ECPR group in ELSO, almost 8,500 patients were reported, and about 30%, nearly 29% survival. And other large cohorts also pretty much similar report. And cardiogenic shock, again, 30 to 39%. Interestingly, the myocarditis group, which has got a very good recovery, even without transplantation, they say that the 5-year survival is around 65%. And another important fact is massive PE. PE seems to be do very well on this VA ECMO. Its survival to discharge is around about 75%. Next one, please. Just specifically looking at the post-cardiectomy outcome here in the adult settings, we can potentially manage 1/3 of patient, salvage 1/3 of patient post-cardiac surgery. And even recent evidence is telling large cohorts is around 36 to 40% maximum. But in post-cardiectomy group, post-heart transplant ECMO support, 1-year survival seems to be absolutely very good. And here in Manchester, we use ECMO very often. Our result is pretty much similar to that, even slightly better. So if you look at further in detail into the post-cardiectomy group, ECMO after CABG survival is about 30%. But if you look into the valvular group, like mitral or aortic valve, basically their survival is even worse than 30%. I think it's mainly due to their myocardial fibrosis and long-standing pathology with the mitral regurgitation, aortic stenosis, and so on. Next, please. This is a pediatric setting. A long time back, actually, at Leicester, I did this pediatric, did a retrospective study on the pediatric cardiac surgery group. It's a heterogeneous population. You can see it's total of 53 patients, varying from tetralogy of Fallot to single ventricles, and median age of 5. You can see 66% went from ECMO, and about 54% discharged from hospital, and about nearly 40% alive up to 75 months, which is pretty good results, which is still to date, it's in line with the ELSO registry. Next one, please. If you look at this current ELSO registry, about 12,800 cases were pediatric VA ECMO, and winning from ECMO about 72%, but 53% survival to discharge. As you can clearly see, nearly 20% of them die even after winning from ECMO. So it's certainly the pediatric population, the outcome on a VA ECMO is better than the adult. I think it's more to do with the myocardial reserve of the kids, as well as the right ventricular predominance on the pediatric age group. And the VA ECMO seems to be a very good post-cardiectomy support. Next one, please. Looking into complications of ECMO, we always talk in two headlines on these. One is the patient-related complications, like intracranial hemorrhage and ischemic stroke, bleeding and vascular complications, and organ failure and multi-organ failure. Device-related complication, as you can see the picture here, which is the oxygenator with the clots on a patient with sickle cell ECMO, a sickle cell patient, we use ECMO. You can see it's full of clot. So oxygenator failure is one of the common things. And the tube rupture used to be common in the past when we were using the roller pump, which is a bit less common now in the centrifugal pump era now. Cannula displacement is another disaster, and pump failures can happen. Next one, please. So in summary, modified VA ECMO is extension of modified advanced cardiopulmonary support, which is used for potentially reversible cardiopulmonary failure, which fails for conventional treatment. Common indications are cardiogenic shock, ECPR, post-cardiectomy, and bridge to transplant or VAD. Prevention of LV distension and optimal coronary perfusion is crucial for myocardial recovery. Outcome varies, depends on the etiology. In general, pediatric outcomes are slightly better than adult, which is around 40%. Patient selection and early application is a crucial factor for success. Thank you.
Thank you so much, Sendhil. So we won't take any more questions. We will just continue with the presentation.
My name is Elena. I'm one of the perfusionists at Wittenshire Hospital. And tonight I will talk about the perspective of perfusionists on ECMO intervention. So without further ado, this is what I will talk about tonight, hopefully over the next 20 minutes, and then on to Laura. So after a brief overview of what we do at Wythenshawe, I will discuss the technicalities of ECMO, and then show you how our unit works from retrieving a patient to deal with emergencies to look after a patient in the unit. So at this point, I'm sure you all know that Wythenshawe is located in South Manchester, and it's a transplant and ECMO centre from the northwest of England, sometimes further than that, because it's not the first time we've had to go to Scotland or Northern Ireland for a patient. We do all forms of ECMO, from VA, VV, ECMO, CPR, and we do most forms of short and long-term ventricular assist devices as well. To start with, the first thing we need in order to put a patient on ECMO is a pair of cannulas. There are various forms of cannulation depending on the type of support, which have been already discussed by Tim and Sendhil. But essentially, we need a cannula to drain blood out of the patient and a cannula to return blood to the patient, which is why we call them return and drainage. Cannulas come in all forms, shapes, and sizes. And let's talk about the differences between them. So to start with, we have those blue cannulas here on the left. So these are drainage cannulas and are heavily reinforced with wires, because drainage equals negative pressure, and these wires prevent the tubing from collapsing. You can see here that the blue drainage cannula have a series of holes or ports along the length of the cannula, and these allows draining from all of them. On the other side, the arterial cannula, which is this red one in here, tends to have just one or two ports at the end. So this directs the flow directly into a vessel. So in this particular scenario, we have a PV ECMO. So you can see that the return cannula is directing the blood directly across the tracheosphere valve. We also have dual lumen cannulas, like the Haval, and Tim show you a slide on that, so I'm not going to touch much further on that. So I'm sorry about this, some physics at this time of the day, but considering the wide variety of cannulas we have, how do we know which one to select for each patient? So first of all, we need to estimate the patient's requirements, and to calculate what we call the flow, we look at the height and weight of the patient and to find their body surface area. And we use what is called the Dubois formula. And then we relate this number with the cardiac index, which I will show you. We use about 2.4 liters per minute. And most adult patients, we require a blood flow of around 3.5 to 5 liters in general. And then we select a cannula depending on how much flow we need to deliver to this patient. Ideally, we like to see what we call laminar flow. So as you can see, all is straight in line, really nice. Within the ECMO cannulas and the surrogate. This is because when the pressure in the cannula is too high, you can see the pressure rising in here, it will be a point where the flow changes from laminar to turbulent, which is highlighted here on the right. And what happens with turbulence is that it increases the energy required to drive the blood flow forward, because it will cause friction against the vessel wall, which consequently will cause loss of energy, and eventually we will lose flow and pressure, which is not ideal. And what happens as well is the problems with the friction and high pressure inside the vessel wall can lead to what we call sandblasting or jet effect. And this is basically tissue erosion, so we don't like that. And this is why it's so important to select a cannula that fits a patient. So on to the next. So when a perfusionist look at the cannula profile, we generally like looking at these graphs. So on the y-axis, you can see the pressure in millimeters of mercury, and on the x, you can see the flow in liters per minute. So each line represents one cannula, one size of cannula. So we have a look at this one, which is a 20 French arterial or return cannula. We can see that this cannula copes with a flow from 0-ish to just about under 2 liters. So what happens if we go over 2 liters? What happens at this point is turbulent flow is likely to happen. So if we are going to deliver 2.5 liters to this patient, for example, we would like to go on to the next one rather than have this cannula working that hard. So on the other hand, at the bottom of this cannula, you can see the drainage ones, and you can see that the pressure is represented in negative in here. And this is because of the force of the centrifugal pump draining all the blood of the patient. And we don't like to see negative pressures of like further than 150. Number one, because this is going to collapse the cannula flat. And then number two, because we are going to cause loss of hemolysis into the patient. This is not a sponsor slide or anything, but I would like to recommend you this app. It's called iPerfuse, and I find it really, really useful, especially when we are on retrievals, because it has like loads of features, including a flow calculator and loads of these graphs that we perfusionists like. So it's quite handy when you're out, I think. Next, this is a diagram that you've already seen of an ECMO circuit. I find it really easy. It's just blood and in and then out with a few things happening in between. But essentially, there are three main components. We have a pump, an oxygenator, and then a console. So just to show you how far we've come, I'm just going to show you a few pictures that Laura kindly forwarded to me. So this is one of the first ECMO patients. And then on the next one, you can see our circuit in 2010, back on the swine flu pandemic. And on the right, this is our current circuit, which is really compact and user-friendly. So we use the Lavitronic CentriMag pump, and then we have a Paragon Maxi oxygenator. So again, I'm really sorry to start with this, but let's talk about centrifugal pumps. So here you can see our CentriMag pump, which has got about a priming volume about 30 mils, and we are able to achieve just up to 10 liters-ish a minute. So centrifugal pump consists of an impeller arranged with a nest of smooth plastic cones inside a plastic housing. And the impeller couples magnetically with an electric motor, which is this metal bit in here. So the magnet inside the disposable pump head spins in conjunction with another magnet spinning in the driving console. And this magnetic coupling means that the speed of the driver magnet inside the console equals the rotational speed in the pump. So when the impeller rotates, it generates a pressure difference. So you get negative pressure, which is draining the patient here, and then positive pressure, like expelling the blood of the patient, and that's what creates flow. So the good, but also bad thing about centrifugal pumps is that they are non-occlusive and they're preload and afterload dependent. So this means that when the impeller is not spinning, fluid can flow in both directions, so in the right direction and in the wrong direction. So if for any reason the pump stops spinning and your line towards the patient is not clamped, you can get retrograde flow, which again is not ideal. They cannot overpressurize, which is good, but as I mentioned earlier, they can generate a huge amount of negative pressure if this is spinning. So if for some reason your line here is clamped, it's going to create loads of negative pressure because it's going to try and suck that blood there. So next on to oxygenators. So here you can see the one we use, which is the Paragon Maxi. It generally handles very well up to 8 liters a minute. The priming volume is about 300 mils and is made of PMP or polymethyl propylene. I know Sendhil touched a bit about coatings. This particular one is coated with what we call RioPack, which is a form of synthetic albumin, which improves compatibility and also reduces the platelets from sticking in the oxygenator. So an oxygenator basically is an artificial lung that allows CO2 and oxygen exchange similar to the one in the alveoli. And we also control the temperature with the oxygenator, which is great. So to start with, you can see here on the right the graph of the path of different things across the oxy. So the blue one is going to be the water, the green lines is the gas, and the red is obviously blood. So first of all, the blood passes through the heat exchanger phase, and this is because if there is like a massive change of temperature, some bubbles might come out of solution. So you want that to be absorbed first, if that makes sense. So the heat exchanger incorporates fins that channel blood into thin layers to increase heat exchanger efficiency. And then after the blood passes through the heat exchanger phase, it goes into the gas exchanger phase. So blood generally flows outside the fiber, whilst gas flows inside the fiber, and they go in opposite directions, which is what we call countercurrent mechanism. You can see here that the gas go in this direction and the blood goes this direction. It's like the same as if you were running and you're running along with your partner and then you sort of touch each other. It's not much of a concussion. Whereas if you're running towards each other, it's going to be more of a clash. So it's going to be like an enhanced touch, an enhanced gas exchange. Other equipment that we use for ECMO, you can see in here. So we have pigtails. Our surgical within Shaw, because we only use it for adults, it's quite simple, especially if you compare it to the pediatric one. So we only have 3 pigtails. So we have this one here on top, and then these 2 that we use for pressure transducing. And this one at the top, we tend to use it just for emergencies, if we need to add any volume or de-airing. And because it's also pre-membrane, we can use it if needed for pressure monitoring. Our pressure transducers, so they are located in here and here. So this one, the bottom, is what we call P1, and it's pre-membrane. So this one will tell you the pressure that the blood has to overcome to pass through the oxygenator. So it's like really relevant to tell you how the fibers in the oxygenator are coping. And this one is post-oxygenator, and we call it P2. So this one tends to give you more information of the patient, what happens after the oxygenator. So let's say, so for example, if your line is clamped, like this will give you information. And we also monitor the difference between these pressures, and this is what we call the gradient, and it's always displayed on the screen. We also have a flow probe that you can see here in the corner, and this also acts as a bubble detector. They are ultrasonic, hence why they are able to detect the difference of weight transmission between blood and air. And finally, we use a hidden cooler, as I mentioned previously, and it's somewhere hidden here. Those blue lines that you can see in here, if we need to cool or rewarm the patient, we use those. Here are another slides. So as you can see, we run filters through our circuits, and we do that quite a lot within Shaw, particularly because the vascular access in this patient is really poor. So we just use the ECMO. We attach the draining port of the filter in here. So in my head, doesn't make sense because the different color, like you generally associate blue with drainage and red with return, but the filter is the other way around to make it a bit more confusing. So yes, we drain from here and then re-inject whatever we filter through here, pre-membrane, in case there is any bubble, the oxygenator is going to catch it. And the same applies to plasmapheresis. One basic tip I think is worth mentioning. If you have a patient in ICU where you're running filter through your ECMO and then you see your oxygenator pressures that are increasing, they are not right. Before you start considering that your oxygenator is clotting, it's worth just stopping your filter and reassess the pressures there, because most of the time it's just the filter putting loads of pressure in the system. So how do we prime our circuit? So here you see a few priming solutions. And within Shaw, we tend to just use Harmans, but sometimes we use blood if the patients are really anemic. I've never done albumin, but I guess it's possible. This table comes from a big randomized control trial where they look at different priming solutions for bypass. Unfortunately, after a lot of looking, I couldn't find much data about priming ECMO solutions, so I just put the bypass one because it's quite similar. And as you can see in this box at the bottom, the pH and the osmolality of both plasmolite and Harmans is quite similar to the blood, and that's why we like these solutions instead of glucose or just normal saline. Tim touched a bit on retrieval, so not going to put much time on this slide. You already know who goes. I think it's worth mentioning that all the equipment we bring is a lot, so that includes from a TOE probe to loads of ECMO cannulas and the transport barriers. And it's also worth mentioning that when we are out, we find ourselves in a foreign environment, and there are a lot of challenges associated with this, from logistical nightmares to just simply finding where the toilet is. So this is one of our air ambulances. I think Tim showed you a few more interesting pictures of this. And this is our very compact ECMO CPR trolley in case we need to retrieve a patient from our hospital or A&E. So it's got wheels on it and it's really easy to move around. Tim told you what happened with the swine flu around 10 years ago when Wythenshawe was selected to be one of the ECMO centres. So initially, perfusionists started to look after the circuit, but because of the impact that this had on the service, we had an ECMO meeting, an MDT meeting, and it was decided that nurses will go ECMO training so they could look after the ECMO rather than as perfusionists. So in order to deal with emergencies or even to just the day-to-day care, our work planning looks a bit like this. So first of all, we have ECMO nurses by the bedside, and don't forget about an ECMO coordinator that is always on duty. And we have an ECMO consultant, and then perfusionists. We get the best part of the job because we only work 8 to 6, but we are always a phone call away 24/7, so we are always within reach if needed. In case of emergencies, we have loads of backup equipment ready available. So we have a prime circuit in the unit, we have backup console with every patient, and we have like emergency box by the bedside if something happens. So yeah. However, the key for preventing accident is monitoring, because most of these problems that can happen, they are completely preventable. For example, we know an oxygenator is starting to clot because we can look at the trend within the shift. So we can look at the pressure pattern over the shift and we know the direction it's going. All of our ECMO staff undergoes extensive training, and Laura will tell you more about this in her presentation. And everyone is familiar with the emergency protocol, so you can see one example here on the left. And also problem-solving algorithms like this one for decreasing PO2 during ECMO are taught during our simulation and training. And now into the interesting bit. So here are the issues we can have whilst looking after an ECMO patient. Some of the most common ones are described here. For example, recirculation, canal malpositioning, increase in oxygenation or flow demands. And I have a slide on these 3 next. We have volume issues as well, quite a bit. So we tend to recognize this by line chattering and a drop in flow, and generally bolus of fluid tends to work really well. And we also cannot have problems with sedation. So this tends to happen when the patients are really light, or for example, they are coughing. And what happens is the intrathoracic pressure changes, and this can affect both the drainage and the return. This is easily solvable as well, just increasing sedation, and sometimes we even need to paralyze the patients, but this tends to work. And then we tend to see fibrin formation quite a bit as well. So in this oxygenator, you can see some fibrin deposits in here and here as well. They're pretty normal, especially if the patient has been on ECMO for a long time, and we just tend to monitor them to make sure the pressures and the oxygenation is fine. And as I mentioned earlier, this is recirculation. So you can see on the picture at the right that if both the return cannula and the drainage are really close together, there's this risk of the oxygenated blood to be suctioned straight into the drainage cannula instead of going into the patient. So if it doesn't go to the patient, that means that the patient is not getting enough oxygen. This is actually quite easy to diagnose as well. You tend to see red blood flashes in the drainage cannula, and also the first probably parameter you notice is that your arterial saturation is starting to drop. What we do in this case is we tend to calculate the percentage with this formula, which is very easy. And then if we are not convinced, then we go with imaging, so chest X-ray or TOE. And then if it shows that circulation is massive, then we just first try and reduce the flow, because obviously the higher flow it is, the longest this distance is going to be. So if we reduce it, it's going to be more likely to go across tricuspid valve and no straight into the drainage. And then if this doesn't work, we just reposition the cannulas a tiny bit. And then sometimes we encounter patients where the flow demand is that high that we can't satisfy their oxygen requirements. For example, in septic patients where the metabolic rate increases dramatically. So in these cases, we can use 2 oxygenators instead of 1, like I'm showing in that picture. And then we have this. So if any real emergency arises, perfusionists will be most likely to be there. But what are the bad emergencies associated with ECMO therapy? So you can see a list of the very, very bad things that can happen and no one wants to see. Some of them are more likely than others. And the one that we tend to encounter the most is clotting, because that leads to oxygenator failure. And this is likely related to ECMO patients being quite coagulopathic, where finding a balance between bleeding and clotting is really challenging. The solution, unfortunately, for most of these problems, like a pump failure, circuit rupture, electrical failure, you name it, tends to be replace the affected part of the circuit, which is not a really nice job to do. I would like you to show you this picture of a reperfusion cannula, and it's also a really good picture to see the color difference between them, both the drainage and the return. So we use reperfusion cannulas during VA ECMO. It's a really small cannula, which is generally a 6 French, and it's attached to the return cannula, so it's oxygenated blood, and it's pointing this direction. So it directs oxygenated blood to the lower part of the limb, just to avoid ischemia. Because of the way these cannulas tend to be attached to the return cannula, you can see it's like a connector sticking out in here. And because it's also attached to a very high pressure system, it's paramount to be extra careful when mobilizing these patients, as accidental disconnection rupture can happen. And obviously, I'm not talking from experience. As I mentioned earlier, the key to prevent accidents is monitoring. However, training and simulation play a big part when it comes to prevention. Our perfusionists regularly help with training, and we train mainly nurses and doctors, and we often run simulation sessions like this one that you see on the picture. Again, Laura will tell you more in depth about this in her presentation. So apart from all the dramatic circumstances that I previously described, perfusionists help in other occasions, for example, with patient transport within the unit, to scan, to theatre, you name it. Testing, we're also involved in doing some point of care testing like TEGs and platelet function testing. We also do change outs, whether they are routine or they are emergency. It's always done by perfusionists. And then when it comes to winning, we win and decannulate our VVs in the unit, and our VAs are done in theatre. And in the majority of the cases, we process the blood contained within the ECMO circuit into the cell saver, so we can transfuse that back to the patient, not to make them really anemic. So as a summary, I think hopefully you have an overview of what we do at Wythenshawe. I hope you have a better understanding of what the equipment for ECMO looks like. I hope you understand how a retrieval process works, and I hope you get to understand a bit more how our unit works in terms of work balance with nurses, doctors, and perfusionists. Very aware of the time, so if you have any questions, just send this to this email or just put it in the chat, so Laura can carry on with her presentation.
Thank you to Elena for going through all of the circuit components. It means that I don't have to re-go through all of those things again. So I'll probably make reference to a few things that Elena's gone over, particularly with staffing and what we all do over at Wythenshawe. So if you just go to next slide, please. There we are, great. Okay, so with regards to our service, obviously Tim's highlighted the VV ECMO service and how that's commissioned and run. And also we do as much VA as we do VV over at Wythenshawe. So we need a whole team of people to make this happen. We have a lot of consultants on the ECMO rota who are there on an on-call basis. And it's the same with perfusion, they're there on an on-call basis. But actually at the bedside, we have coordinators. One is always there 24 hours a day. And we have 64 trained ECMO nurses who are trained in all of the things that Elena has just discussed with you, but we'll go through a few of those. If you can just go to next slide, please. Okay, so our nurses that are trained now in-house, as a couple of the talks have highlighted, we've been a commissioned centre since 2011. So we quickly developed our own in-house training. Prior to this, a lot of us had to go down to Leicester to do some training, but we now run everything through Wythenshawe in-house. So we have nurses who have got a minimum of 3 years ICU experience and have also got an ICU qualification in way of the ICU course. Our ECMO course is a 3-day course which is based around theory and simulation. We then have a competency-based assessment that includes a wet lab assessment at the end of a certain amount of hours. 3 days we usually utilise this for. Mandatory training is done obviously annually, and this is where our nurses have to perform all of the emergency situations and do wet labs annually to make sure that they are safe at the bedside. We have minimum circuit requirements with regards to our service spec, and it's only actually about 100 hours a year, but our nurses very much do much more than that, particularly in recent times. Next slide, please. So this is just, it's just the top ends actually of the couple of documents that we have, which are to do with our precepted shift. So it gets our nurses from novice on ECMO to competent on ECMO. And then we have a pass or referral system with regards to our water lab assessments. And some nurses, we find that we do them a couple of times and most people just sail straight through them. Next slide, please. So simulation, I think this has been talked about throughout the other talks as well, but essentially we have an education resource centre within our hospital that we use as simulation. We have an ECMO specific simulator that we can simulate cannulations, problems, flow drops, emergency situations, and we run MDT sim days, so that's mainly the core team of ECMO staff being the ECMO consultants, the perfusionists and the ECMO coordinators. This branches out to nurses when we do in situ simulations, but generally speaking, this is where we run all of our scenario bases that we may encounter on the unit. We've also done 13 ECMO CPR simulations in A&E where we do it in real time, so we get called and we go down and we cannulate the mannequin. Next slide, please. With regards to what our nurses do on the unit, so obviously they have to maintain maintenance and safety of all of the equipment, and this is they have to be trained in all of the emergency situations and troubleshooting things like low flows. Because of this, our ratios to nurse to patient are 2 nurses to 1 patient, generally speaking. If we have 2 stable ECMO patients, we have 3 nurses to care for 2 ECMO patients. We call this single care, and we have one of the nurses acts as a float between the 2 patients. Obviously they need to be competent and have gone through the ECMO course, and they have this responsibility, like I say, to maintain the safety of these patients. There is a whole team support, as Elena alluded to. They're on 8 till 6 on the unit and then they go home, but they are on an on-call basis. So there's certain things that we have to do as coordinators that are a bit more enhanced to the ECMO trained nurses that are on the unit. Next slide, please. This is just our emergency protocol. So if we do have any issues, this prompts us to call the appropriate people at the appropriate time. So for example, if we have an emergency happen at 2 a.m, half of these people that you can see on this list aren't actually on the unit. So we grab this straight away, and this enables us for somebody to call them in as soon as possible, rather than getting 20 minutes into an emergency and realising that nobody called the perfusionist, for example. Next slide, please. The back of this emergency protocol just gives everybody identified roles. So this just tells us who's responsible for which bit, really. And this enables the circuit to be looked after by the appropriate people with regards to trained people. And it allows the rest of the staff to look after the patient as well. Because what quite often happens in an ECMO emergency is everybody just goes straight to the circuit, and then you find that nobody's actually looking after the patient. So this allows for everybody to be in the right place at the right time. Next slide, please. This is our emergency prime circuit that Elena discussed before. It's just a picture of it. We keep it in a lock cupboard. Unfortunately, it's only ourselves as coordinators and perfusionists that have access to this. We do have facility for spare cannulas and dilators, and we have a lot of other equipment on the unit, but this is a very quick, if we had a circuit failure, oxygenator, blockage, a recannulation, anything like this, even out of hours, our ECMO coordinators go on enhanced training every 6 months to be able to cut this in. Luckily, this doesn't happen very often. And usually if we've got a problem with a patient, most of the staff are there. So perfusion are called a reasonable time, usually. Next slide, please. So that's sort of everything about the nurses sort of training and what they are responsible for. Obviously, they need to be trained in respiratory and cardiac ECMO, and they're very specialised nurses anyway because of the unit that we are based on that Tim alluded to before with regards to transplant and cardiac surgery. So I'm just going to talk just a little bit about the changes and the challenges that have come with more recent times in COVID-19. Tim highlighted the national referral system that actually got implemented at the start of April. The demand on the national service from a respiratory point of view was huge, and you saw some of the slides as well from Sendhil with regards to the Euro-ELSO data and the thousands and thousands of patients that have been on ECMO. So as a service nationally, approval of surge up to 100 patients was granted, which at first we thought was crazy. And then actually at the height of it all, we ended up with over 90 patients in this country on ECMO at one given time, which has never happened before. Prior to this, it was around 38. Clinical guidance changes, which Tim showed you earlier. We also had to suspend some elective surgery, and we had to do a lot of elective planning, escalation planning strategies to allow us to take up to 20 patients at once. Obviously, this has a big impact on lots of things. So I'm just going to break those down into sort of 3 key areas and what impact they had on staff, personnel, equipment, and the space really, which we'll call estates. Next slide, please. So from a personnel point of view, obviously this changed massively what we do under a normal circumstance with regards to our rotas. Perfusion, for example, did stay for 24/7, whereas usually they are 8 till 6. Our consultants also stayed overnight, and usually they're on call. So things change with our rotas quite a lot. With the nursing side, not so much, but with the other people it did. Our ratios, however, from a nursing point of view, we went from looking after 1 circuit to looking after 2 circuits, sometimes up to 3 circuits. When we had perfusion there, we could have up to 6 circuits looked after by perfusion, as long as we had other ECMO trained staff in the zones. Fit testing was a big challenge. We would fit test people for an appropriate mask, and then the next week those masks wouldn't be available nationally, so we would have to go through all the fit testing of all our staff again. So it just meant that one person, more than one person actually, was responsible for fit testing all of the time. Use of perfusion we've talked about, and consultants out of hours. We also employed task teams. Staff from other areas came in to help with filter management, to help with sedation, the levels of sedation that we have, and drug usage, and also tasks in proning patients on ECMO, because we do that a lot, and we did this a lot in COVID-19. There was a massive demand on the clerical work. So Tim highlighted the figures for you earlier on. We did a year's work in about 6 weeks, and with regards to all of the referrals, and all of the referrals require some form of contact and management and follow-up, and obviously to keep all of this data. Next slide, please. So from an equipment point of view, we had new equipment that we purchased, not much with way of ECMO equipment. In fact, we had to loan that from some other areas. National centres were asked to provide the sort of ECMO commission centres with the equipment that they had. We had new ventilators and other bits of equipment as well, but essentially we could escalate up to 16 during the COVID pandemic, even though we were supposed to be planning for 20. We never quite got there with the numbers. Each bit of equipment, you need a backup bit of equipment. So we've talked about things that can happen with motor failures and console failures. So if this were to happen, we have to have a backup. Usually this is at each bed area. During the COVID-19 pandemic, when we had lots of patients on at once, we would share this emergency equipment within the zones. And we've talked a little bit about PPE as well, and constant change because of shortages with regards to PPE. Next slide, please. And then we need to think about where these patients would go. Our ICU is quite unique in the way that we have other services running through. And obviously with these patients, we really needed to think about infection prevention and control. Luckily, we have different zones that we can keep these patients in and different cubicles. So cohorting the patients to make our ratios work was a big thing. We explored a couple of different areas that potentially we could move ECMO onto, but in the end it was thought that our ICU was the best place for these patients. So we actually opened other areas as general ICUs, and I think we had about 4 separate areas within Shore Hospital that were opened up as a makeshift ICU area that wouldn't normally be used for that. NHS England commissioned for 2 additional surge centres just during the pandemic to help out, and actually they only took a couple of patients, but at the time that was a massive help. Daily reporting from a national status and dialing into conference calls every day to look at capacity, where was the next bed available, and also learning from experience from each other as well, and what was happening with the evolving COVID-19 virus itself and how we were going to manage this. As Tim talked about earlier, the complications and the management of these patients was very difficult with regards to bleeding, clotting, steroid use, and things that we were developing in guidelines as the time went on. Next slide, please. Other considerations were things like the amount of sedation we were using, the amount of drug usage, hemofiltration, and having that via multi-system support. Over 40% of the patients required hemofiltration. Our blood product supply as well was obviously in great demand. Usually we would keep 4 units of blood, and we downgraded that to 2 units of blood, but our usage was much higher. Next slide, please. And this is just to illustrate the 36 patients. The 37th patient is still on ECMO, so I don't have their usage. But essentially, this is much more than what we would normally see with our usual groups of ECMO patients, respiratory ECMO. Next slide, please. This was our escalation plan at the Wythenshawe site, and as you can see, we had to think about the location of these patients, where they would be based, how much staff we would need, what that would do to the other ICUs within the hospital, and what actual impact this would have on other services that we're running through. Next slide, please. So of this, we got to stage 5, where we actually went up to 14 patients at any given time. This was the maximum that we actually went up to. And you can see there the staffing implication of that. And also all elective cases and surgeries actually had to stop, and a couple of emergencies were transferred out to other hospitals. We did manage to keep the transplant service open, although we didn't do any transplants during this sort of period of time. We did have an acute heart failure patient who was on a BioVad with an oxygenator who was COVID, who did very well actually. But other than that, we would have been able to do a transplant. We're not sure where that patient would have gone in way of ICU, but we would have been able to do it. Next slide, please. So I think this is the biggest thing for me actually as a nurse. So I think the actual impact on people was phenomenal, and I think we've seen this now as people come to debrief, sort of not post, because we're very much still within this pandemic with patients still with COVID-19, but the decision making and the criteria changes were very difficult on our service, on our referral pathway, on our consultants making these decisions. Essentially, we were saying no to patients that we would normally say yes to, because we were having to prioritise very young, fit patients usually, and changing our criteria. The clinical management we've talked about was very challenging in this group of patients, and the ways that we worked were very different to the way that we would normally work. PPE was obviously a very big issue with regards to being in it all day for 12 hours. When you were in these zones and in these cohorted areas, that was the equipment that you needed to have on the whole time. And I think one of the biggest impacts was not having relatives actually able to come into hospital to visit these patients. And although they're not awake, these patients, they are sedated. I think that usually the relatives get a very good relationship with the staff, the nursing staff and the medical staff, and they get regular updates and they're able to see their relative. And this was a massive pull actually for everybody, because there were patients who obviously didn't make it. Currently 59% of our patients didn't survive. So you can see that, you know, a lot of patients actually dying alone and their relatives not being able to see them was probably one of the biggest impacts that will stay with a lot of our staff for a very, very long time. That's it. That's the end of my talk. Like I say, I didn't want to go over all the complications too much, but essentially all of our nurses are trained in the management of these patients, all of the emergency situations, and the coordinators have a bit more of an enhanced role and work with the perfusionist a little bit closer. Thank you very much, everybody, for your time.
Thank you so much. Our next speaker is Sagar, Mr. Sagar Haval, and he is a clinical ECMO specialist from Getinge. Sagar, over to you, please.
Thank you, Bhuwana, for inviting me to do this presentation. I'm just connecting my PowerPoint. All right, so as Bhuwana said, actually, I work with Getinge as a clinical application manager for cardiopulmonary. I do trainings on ECMO and all perfusion-related therapies. I worked in the past as a perfusionist and also worked as ECMO coordinator for a few years. And yeah, so the topic given to me was to cover quite a few things. Yeah, so some of the slides actually will be kind of repetitive for you, so please bear with me. So I'll be covering ECMO therapy, ECMO systems, outcomes, and ECMO in COVID-19. As you know, ECMO, the first, as Sendhil said, that the first case was done in early 1970s. And since then, there has been a big change in a clinical approach and technology. In fact, the decision-making process, the management, everything has changed compared to the past. Basically, ECMO is a modified form of cardiopulmonary bypass, which is used to treat patients with refractory conventional therapy, refractory respiratory endocardic failure. And it is used as a bridge to recovery, bridge to decision, bridge to bridge, or bridge to transplant. The main indications, actually, what you look at is hypoxemia, severe hypercarbia, or refractory cardiac arrest or refractory cardiac dysfunction, cardiac failure, and it can also be used for who are unable to wean from cardiopulmonary bypass. So according to those indications, actually, if you look at how these patients are spread all across all the in the hospital, all the departments, you can actually see it can be used into almost every major department in the hospital. Just to give you a brief of actually what ECMO systems and how they look like, I know Elena has already mentioned quite a lot of things, but this is a typical cardiopulmonary bypass circuit where there are lots of things which are connected. And this is a typical ECMO circuit, and where we have cannulae connected to the patient, and then we have a pump, then oxygenator, heat exchanger, and the blood returns back. You will also find some systems actually which look different, and this is a cardiac system where there is the pump, which is actually integrated with the oxygenator, and then the blood is returned back. So it's a very miniaturized system. In fact, I actually read through a couple of questions on negative pressure monitoring and all that. It is all integrated in these devices. I'll just show you some slides later. So Getinge as such manufactures these two different type of devices. One is a permanent life support system using a rotoflow, and another one is a heart-lung support system using CardioHelp. We actually, in fact, have seen a rising product demand in extracorporeal life support systems and ECMO systems, ECMO therapy in this COVID-19 pandemic. And we have actually seen that in some of the countries, the ECMO application has doubled or even tripled some places. So it has been very challenging even for a company to cope up with that kind of a demand. In fact, the manufacturing units are actually literally running 24/7. Production capacity has been increased to 1.5 times the normal. So these are the components. If you can see my mouse, these are the components which are used in ECMO. We also need transducers and a monitor to understand the pressures on that. Sometimes we have to use blood parameter monitoring system to understand hemoglobin, hematocrit, venous oxygen saturation, and stuff like that. And all of these, pump, oxygenator, all of it actually is all required. CardioHelp, if you don't know CardioHelp, actually just to tell you, this has almost all these things which are required for ECMO integrated into one system, except the air oxygen blender and heat exchanger, which is required separately. It is worth noting actually that the complications of ECMO can be very much minimized if you use a specially designed ECMO system, an ECMO circuit. And I've seen, in my personal experience, CardioHelp actually, we have seen that it minimizes a lot of complications. The reason why I'm saying you that is because we have seen low hemolysis with these systems, and that's because of a very low profile component systems and everything. And you can actually see the pump has 4 outlets instead of 1 outlet, and a lot of things which actually are beneficial for minimizing the complications caused because of an extracorporeal circuit during an ECMO. This is a nice picture of coatings where you can see this is an uncoated circuit which is much more patchy under an electron microscope. And this is of a coated circuit which makes the lining more smoother and which minimizes shear stress even at the inside of the tubing. And these cardial patchy circuits do have these coatings which are used to minimize a lot of complications caused because of that. So to get the best outcomes, actually, you have to have a proper team who should be running the ECMO, who should be trained properly, and standardized protocols, proper patient management and selection, and putting the patients at the right time is very important. Proper ECMO system and hardware, disposables is very important. Regular practice and trainings and simulation is very, very important. This is just to give you an overview of the extracorporeal life support registry report. As Sendhil said, and also Tim said, that the outcomes can vary between 73% for neonatal pulmonary. Cardiac, it can be around 43%. So I'm looking at the survival to discharge outcomes, and ECPR is ECMO-assisted cardiopulmonary resuscitation for cardiac arrest. We can actually expect an outcome of around 42% in these cases. If you look at the pediatric cases, the outcome also can range similarly like the neonatal cases, and in adults, the outcomes can range from 29% in ECPR to 60% in pulmonary cases. Extracorporeal Life Support Organization was established in 1989. So since then, since 1989, they have been running a registry, and there have been an increase in the number of cases and number of centers supporting ECMO globally. In fact, this actually misses around 30 to 40% of the data, which from the centers which are not registered with ELSO. But you can get an idea from here that there are around 16,000 cases reported last year, and around 460 plus centers which are reporting that data. And if you look at the outcomes, as I mentioned before, in neonatal cases, the outcomes can be much better depending on the indication. Meconium aspiration has a best outcome of around 90-94%. And in refractory cardiac arrest, the outcomes can be around 22%. It all depends on the timing. And in pediatric, it is kind of similar. We have got 35% outcome, and actually that's the minimum you can actually expect from post-cardiotomy cases. And in severe myocarditis, you can actually expect an outcome of around 73%. This is all from Extracorporeal Life Support Organization registry report. So if you're interested, you can actually go online and see. And in adults, similar. So 27% in refractory cardiac arrest, and in patients with severe myocarditis, they can actually show an outcome of around 69%. And as Sendhil said, in patients with pulmonary embolectomy or embolization, the outcomes can be even 80%, 70 to 80% actually. So this is a slide on COVID-19, and as everybody, we all are following actually what's happening around the world. Just to give you an update, there have been around 23 million cases which have been confirmed, and this is from Wikipedia. I know there are many other tools to understand the latest report, but this is just to give you an idea. 14.7 million people actually have recovered, and unfortunately 799,000 plus people have died of this COVID. And in the UK, we have 325,000 cases which are confirmed and 41,000 cases which have died. When we compare with the previous pandemics, this COVID-19 actually is slowly going towards the Japanese smallpox epidemic, which sits between 18th century to 18th century Great Plagues and Japanese smallpox. Yeah, and we don't know how big it will grow actually in future. This article was actually published in 19th May 2020, and that time the number of cases actually which were reported were 4.7 million, and in just 3 months actually the number of cases have gone to 23 million. So the number of cases are increasing, and those times the death rate was actually 310,000, and now it is around 800,000, so 790 something. So it has almost increased by 2.5 times. And if you look at the resurgence in COVID-19 cases or deaths, if you look at the peak, we were assuming and we were thinking that the peak was in April, May, but now you can actually look at it, the graph is growing up. And I think the top leading countries are US, India, and Brazil, and they are seeing more number of cases, and we are slowly heading towards the second peak. Corporeal Life Support Organization, they came up with interim report and interim guideline actually for the centers to support COVID-19 patients who require ECMO. And they suggested actually that only the established centers who have experience on ECMO should be put in COVID-19 patients who require ECMO. Just to get better outcomes, and we should be very selective in selecting these patients to get the best outcomes, and which is also very important. There was a plan, and as Laura showed, that centers' capacity were increased from 15 or 20 to 100, and there have been more preparations done. So also, Corporeal Life Support Organization gave an initial guidance for it. And the selection criteria is similar like the VV ECMO selection criteria. Most of the patients actually of COVID-19 went into respiratory failure. And if you look at it, the selection criteria is PF ratio of less than 150. And if you see that, they strongly recommend prone positioning. And if required, neuromuscular blockade and appropriate PEEP given. And sometimes inhaled pulmonary vasodilators or recruitment manures are given. So if after all this, actually, if the PF ratios start dropping, plus if the pH and the PCO2, so pH starts dropping and PCO2 starts increasing, and if there's no contraindication for ECMO, they are indicated for ECMO. And if some patients actually whose PF ratio is good enough, but the pH is dropping and PCO2s tend to increase or have increased in more than 6 hours, and if they are not contraindicated for ECMO, they are indicated for ECMO. So hypoxemic and hypercarbic patients actually are indicated for ECMO if they don't have other complications which would prevent them to be put on ECMO. This was advisory inclusion exclusion criteria by the team in the UK, and they also suggested that potentially reversible severe respiratory failure patients with Murray score of equal to more than 3, and with failed trial of ventilation in prone positioning for more than 6 hours, failed high PEEP ventilation strategy for more than 6 hours, and clinical frailty scale of equal to less than 3, and RESP score of less than equal to 3 should be considered only after agreement across at least 2 centers. And this was the inclusion-exclusion criteria for COVID-19 patients to be put on ECMO. And the exclusion criteria is refractory multi-organ failure and additional things, and the other contraindications which are usual for ECMO. So if you look at the global data of ECMO put on COVID-19 patients actually or supported for COVID-19 patients. So this is the data from Corporeal Life Support Organization registry, and they're running a registry on for COVID-19. Around 2,278 cases were suspected or confirmed, and amongst them, 2,267 cases were confirmed, and in them, actually, some of them are in the hospital. So around 1,603 cases were discharged alive, and amongst them, 891 cases survived, and most of the cases actually have come from North America, and then Europe, then Asia Pacific, and Latin America, and SWAC. I have worked in India and in South Asia, and a lot of centers over there aren't registered with ELSO. So I know there is a lot of data which we are missing, but this just gives you an approximate idea of how exactly things are happening. If you look in detail, okay, on an average, the patient's age was around 48 years old. Around 95% of the patients were put on ECMO for respiratory purposes. And around 3% of the patients were put on ECMO for cardiac. And some patients, so around 1% of the patients had a cardiac arrest with COVID-19 and they were put on ECMO. So if you look at the type of ECMO mode, around 91% of the patients were put on VV ECMO and 4% of the patients were put on Veno-Arterial ECMO. Less than 1% of the patients were put on VVA ECMO, and around 3% of the patients were converted from VV to VA or VA to VV later. Yeah, on an average, the ECMO run time was around 327 hours, which is quite long actually. And the main complications were renal failure, and the intracranial hemorrhage was actually 5%, and less than 1% actually had stroke. And patients off ECMO and still in the hospital is actually at the moment 10% at the moment. Yeah, and okay, there's another thing in this. On an average, patients stayed in the hospital for 29 days. So Okay, so this is just a graphical representation of what I said. Around 2065 cases, and this is a little older data than the data which I showed you. So 2065 cases were put on ECMO, and total discharge of 1,436. And yeah, and if you look at the support type, actually, most of the patients were respiratory cases and put on VV ECMO, and then cardiac and ECPR. And most of the cases came from North America and then Europe after that. If you follow ELSO, Ex-Corporeal Life Support Organization, or EuroELSO, you can actually follow on LinkedIn. You can find regular updates on what's happening around and how these patients are actually being supported and all that. This is a busy slide. It's even for me, it is very difficult to look at the numbers, but I just wanted to tell you that these kind of data, where you can find much more detailed information about patients supported on COVID-19 patients supported on ECMO, can be seen even on the ELSA website or on the LinkedIn page. In fact, at the moment in the UK, there are around 195 cases which are put on ECMO and running. The same way you can actually find data according to the countries. Yeah, that's it. All right then. Thank you, everyone.
Thank you so much, Sagar. And we are happy to take your questions, please. If you want to type it, you can type your questions. Sendhil, there was a question for you. What is the rate of vascular complications of VA ECMO, example thrombosis?
Yes, it depends on the type of VA ECMO, isn't it? I mean, if it is a central VA ECMO, the vascular complications are that not significant. But if it is only the peripheral VA ECMO, especially the one we use, I think Elena replied for that. The one we use for ECPR, percutaneous cannula, and that patients get into vascular complications. And it depends on what type of ECMO you use. And if you use with isolated limb, specific limb distal perfusion cannula, which is nicely shown in Elena talk actually, with the complications are quite minimal. If you don't use this cannula, the complications are going to be there, especially when you are providing percutaneous femoral VA ECMO. I would say that if you don't use the distal perfusion cannula, pretty much it can go up to 50%.
Another question for you. We had a couple of patients with cardiomyopathy on BIVAD where COVID suspected but never confirmed. What do you think?
Well, I think it's a very, very interesting case actually. I think it's initially presented as a cardiogenic shock, and we were discussing whether to go for ECMO or BIVAD, and then what we decided, we go for a BIVAD, which he was recovering but taking quite a lot of time. To cut the long story short, we sent a few tests initially for COVID. BAL samples and things. Unfortunately, they were not positive. But the way he was behaving with his thrombos, with his platelet going down, lymphocyte going down, his antibody seemed to be positive. So he had a COVID while he was on BIVAD, but we put oxygenator as well. And I must say that he did very well, and we weaned him from that, and good myocardial well as, and he went home actually.
Okay, thank you, Sendhil. There is a question for Lara. Lara, you mentioned that during this pandemic, some patients have died alone. In what ways did you manage to communicate with the relatives, and what was your experience?
Thank you. So we were able to utilise Zoom. We had an iPad that we could use, so patients' relatives could actually see their relatives. But obviously, in way of updates and communication, we had regular every other day. Consultants would ring the relatives actually to give them an update, and obviously normal phone calls with the nursing staff. I think it was just very difficult. On some occasions, we did have patients' relatives come in. And one could put on PPE and come with them, but this was under very, very unusual circumstances. But it was very, very difficult for us to do this, especially initially. I think the first maybe 5 to 10 of the 37 patients, perhaps we didn't do any Zoom or any calls so that their relatives could see them, just because we'd not yet got it up and running. But now we certainly do have that in place. But it remains a very, very difficult task really, and very difficult obviously for us to not get that communication and relationship that we would normally build with a relative as well, and they would know us and have trust in us, and that obviously was a lot less during this time period.
I think there is no more questions coming, and to finish off, Elena, do you want to say anything?
No, thank you very much. I really enjoy seeing your presentations. I find the human factor especially quite interesting because it's not generally the side we see. So it's good to mention these things. Thank you, Laura.
Sendhil, do you want to say anything?
Thank you very much for organizing this excellent event, and especially thank you for the participants who are very enthusiastically asking all the questions, and Sagar as well, and all the team. I think it is excellent piece of work, and thank you especially to you, Bhuvana.
Thank you so much, sir. Thank you so much for everyone coming. Sagar, do you want to say anything?
Thank you, Bhuvan. I think I enjoyed these presentations. I think it was really good, very informative. And thanks to everyone actually for being online in this evening and coming from all around the world actually. Thank you. Thank you, Bhuvan.
Thank you so much.